Yeah, so in our time together, I'm just going to take us on a bit of a tour de force through the various ways that artificial intelligence is impacting our world of neurointervention. These are my disclosures, and pertinent to this talk is my relationship with Viz AI. Well, we all know that 2015 forever changed stroke treatment when our 5 New England Journal published trials established mechanical thrombectomy as our standard of care for stroke victims with an emergent large vessel occlusion, or LVO. These trials really uncovered one of the strongest treatment effects that we've seen in medical history, with a number needed to treat of 2.5 to 4 for revascularization by thrombectomy to return a stroke patient back to full independent living. Following these landmark trials, all of our attention was really turned then on how to redesign our stroke systems of care. We wanted to optimize triage, transport, and treatment of LVO patients to thrombectomy-capable centers. The old adage, time is brain, really took on a whole new urgency, with everyone scrambling to improve the flow of stroke patients within their stroke networks in order to optimize efficiencies for delivering this time-dependent interventional treatment. We were looking a lot at the hurdles and obstacles that were really delaying treatment and negatively impacting patient outcomes. If you look at these cities, the challenges to improving the systems of care differ depending on where you're providing this care. Obviously, the challenge is to optimize your stroke network in a small city like Chattanooga, Tennessee, that you see on your left, where I practiced for a number of years, are much, much different than if you're in a large city like in the center of Manhattan. Nevertheless, there are variables that are common to all programs providing advanced stroke care. The most pivotal variable is accurate triage to find the true positive LVO patients who would benefit from thrombectomy. Accurate recognition of these patients who have a high probability of having a large vessel occlusion in the field by EMS is really the holy grail for our therapy. Unfortunately, for EMS, it is like finding a needle in the haystack. The data tells us in the US that an EMS provider will encounter 1 true positive LVO patient per year. There's been a lot of work through activities like SNIS's Get Ahead of Stroke campaign to provide training and resources to our EMS providers. An example is this app that provides many of the large vessel screening tools readily at their fingertips. They can select their screening tool of choice, enter their findings, and determine if their patient is of high suspicion for large vessel occlusion and should be transported to a thrombectomy-capable center for further evaluation. Okay, warp speed to our future, and let's take a look at an AI triage tool that is presently being validated. We're all well aware that everyone on the planet has smartphone technology at their fingertips. We are also aware of the widespread use of facial recognition. This is where AI is used to uniquely identify a person by analyzing patterns based on the person's facial textures and shape. What if a person's facial muscle weakness patterns and speech disturbance could be analyzed and be highly correlated with a stroke? Well, that's what the team at CVAID are bringing into our stroke triage armamentarium. Here's an overview of how their system works. In the field, an EMS provider or nurse opens the Cva Collector App, and then they run a guided examination of the patient. This information is then beamed to the cloud and analyzed using AI technology. The stroke team is notified, and they can view the findings in the patient examination videos in the Cva Med app. Taking a closer look, let's log into the Cva Collector app. First, the patient data, symptoms, and symptom onset times are entered. Next, using the smartphone's camera, an examination is initiated. The patient's asked a number of simple questions, and the response is recorded. The patient's then asked to perform simple tasks like smiling and showing their teeth. Here's a video demonstrating the examiner capturing the patient being asked to raise both hands vertically and hold them in the air for 10 seconds.
Please raise both hands vertically. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. You can take the hands down. Thank you.
Once the examination is completed, the files are beamed to the cloud. Using AI and machine learning techniques, a digital stroke scale score is then determined. The stroke team is then alerted, and based on the review of the data, the patient is transported to the appropriate stroke treatment facility. Okay, so now we've triaged our patient and they've been transported to the appropriate treatment center for further evaluation. The next step to efficiently get them from the emergency room doors from the emergency room doors to imaging. We aim for a door to picture target goal at 10 minutes. As you all know, this requires a lot of streamlining, especially for getting the patient registered into your hospital in order to meet this very quick time metric. The vast majority of our programs then use CT as their imaging tool for identifying large vessel occlusion patients. I'm sure a lot of you are practicing now in programs that then use AI software to analyze this CT data. Two of the most recognized AI platforms that are in widespread use to analyze imaging data are the VisAI and Rapid technologies. There is, however, like all technology, an explosion of software providers entering this space. A number of these providers are listed here. These platforms compete to offer complete AI brain imaging that analyzes all of the imaging relevant to the evaluation of both the ischemic and hemorrhagic stroke patients. The imaging can be easily viewed on the platform's app. Within minutes of acquiring the imaging, the data is being analyzed by AI and the treatment team is notified of positive findings. With the entire treatment team having access to this platform, findings and the treatment decisions can be easily communicated in a HIPAA or patient information compliant manner. We all know that the traditional way that we were arriving at identifying the true positive large vessel occlusion patients and then communicating the decision to proceed with treatment was very slow. When we measured these times in studies and registries like the Stratus registry, they were unacceptably long. These delays often precluded the patient from being a thrombectomy candidate when they arrived at our treatment center, or negatively impacted their chance to make a good clinical outcome if thrombectomy was performed. When a stroke program implements the utilization of an AI analysis tool, we see tremendous savings on the order of hours in times to treatment. Time savings are obviously extremely important in impacting patient outcomes, but we also need to take a look at how these AI tools are performing compared to us mere mortals. This data is reassuring to know that the technology is extremely sensitive and specific, but it also hurts our pride a little when we think that we can far outperform technology. Let's take a look at other things that AI is analyzing. In assigning an aspect score in the evaluation of a stroke patient, we also know from studies that there can be a large inter and even intra-observer variability. Well, again, the studies are humbling, showing that automated aspect scores are more accurate than experienced clinicians. Let's take a look at how AI is performing in ICH detection. This data that was published in AJNR demonstrates that the accuracy of automated detection of intracerebral hemorrhage is also very impressive. So we can conclude that AI is performing very well and showing us tremendous efficiency gains, but it's important to note that AI isn't perfect. For instance, where AI failed in ICH detection were the small bleeds that were less than 1.5 ml in volume. If you ask our clinician champions who are pioneering this technology, like Greg Elbers from Rapid or Chris Mancy from Viz, what is our future with AI? They tell us that it's a powerful tool to be used adjunctively to help us arrive at a quick diagnosis, but that we really aren't to quit our day jobs just yet. Overreading by the clinicians involved in making the decisions is still critical, and it is still the notified clinician who is responsible for assessing the images and making and confirming the diagnosis to treat. Well, we've used up our time to look at artificial intelligence and its impact in neurointervention. I'm going to save for the future how I can jump to retirement pretty soon when robotics are taking our place in the procedural world. But I'll leave that again for another day. Right now, I'm just adhering to the proverb, if you can't beat them, join them. So I thank you for your attention, and I'm going to finish my comments there. And I want to thank definitely Dr. Orlov and his amazing team for providing me this opportunity to be with you, even if it is virtually. So enjoy your meeting, and I'll take any questions if you have them.